All right. Okay, so this is your information for CEUCE, CMEs. I have nothing to disclose in regards to this presentation. Today we're going to talk briefly about basic concepts of CBT, or cognitive behavioral therapy, and I'm going to go over three specific interventions that fall under the CBT umbrella of relapse prevention. So a very quick and dirty review of what CBT is, its basic components, and how to apply it. And then we're going to walk through three core interventions that you can use: trigger and trigger identification, urge and craving management, behavioral contingencies, and high-risk situation planning, which fall under that umbrella. To kind of ground where relapse prevention strategies fall in, most of you are probably familiar with this model, the stages of change model, recognizing that we want to use different types of intervention dependent on where a patient is in their stage of change. So we are not going to start applying any of the concepts that we're going to talk about today until patients enter the action stage. And really primarily once they've moved into maintenance. You can apply all of the interventions I'm going to talk about starting in action, but they're really most appropriate in that maintenance level because we're wanting to prevent relapse, which is a common occurrence with any substance use disorder. So this is really where they tend to live. This is another model that helps you kind of tie into sort of where these interventions sit. So really when somebody is early in recovery, what we're trying to do is apply basic harm reduction. So we're wanting them to improve their global health and start to decrease their use. Once they move again into that contemplation action, so they're ready to actually do some things, then we can use CBT techniques. And then relapse prevention once they've moved into very solidly action and into maintenance where we're trying to prevent relapse. So let's talk about what CBT is. Well, it is a talk therapy which really helps teach patients how to link their thoughts, feelings, and behaviors. It has really good solid evidence for treating all kinds of addiction, and it's been used anywhere from tobacco to opiate use disorder. So it can be applied for pretty much any use disorder. It's also highly flexible. So if you have a CBT manual, you can pull out components of that manual. It's always good to stick with a solid protocol, but if that's not your role with a patient and you just want to be able to apply sort of like one of these techniques, it's flexible in that way. You can just use a specific intervention. It's short-term and it's meant to be highly focused, and what that means is we want to identify target symptoms or target behaviors that we want to change, and the interventions are aimed at doing that. The way to think about CBT is to understand that people always have a thought before they have a feeling, before they engage in a behavior. So this is called the CBT cycle. So you can see that what's sitting outside of the cycle is the activating trigger or activating incident. So essentially something happens and then the person has a thought about that something. That thought could be rational or based on reality, or that thought could be irrational or sort of not based on reality. And that thought is then going to connect to how the person feels and how their body responds to those emotions, and then the behaviors that they engage in. So a good example is to think about a common event like driving down the freeway and somebody pulls out in front of you in traffic. That would be the activating trigger, the person pulling out in front of you in traffic. Now, most of us will have an immediate thought that is probably not super grounded in reality, but the thought is, what a jerk, right? So that thought is going to be directly related to an emotion, primarily anger. So what a jerk, I feel angry. My body is going to respond to that anger. I'll probably have an increase in cortisol or adrenaline. My body temperature might rise. And then my behavior is going to be directly connected to both that thought and that emotion. So I'm likely to step on the accelerator, tailgate, maybe honk my horn. So that's that chain of events that occurs 100% based on that thought of what a jerk. Now, if we take the same incident and someone pulls out in front of us in traffic, and instead of having the thought, what a jerk, I have the thought, oh no, I hope they're okay. Maybe they're having an emergency. Again, I have no proof either way, so this thought could be realistic or unrealistic, but it's going to be connected to a completely different set of emotions. So that emotion would probably be something like concern, and then that's not going to result in the same physiological response. And then my behaviors are going to be very different. So if I'm feeling the emotion of concern, or maybe even compassion, then I'm probably going to slow down, give them more space, maybe even change lanes. I'm not going to engage in the same series of behaviors. So when we're using CBT techniques, we're teaching this cycle to patients to help them understand where they can intervene. Because typically we can't intervene at the level of emotion and physiognomy, so our physical response, but we can intervene at the level of cognition and behavior. So if we change what we're thinking, we're going to change everything downstream. And vice versa, if we change the behaviors that we're engaging in, we're also going to change the things that we're thinking. So we can intervene in either of these areas. So that's basic CBT. In CBT, our sessions should be highly structured and the clinician should be active. So this is not a passive or open-ended type of intervention. Most CBT sessions tend to be about 60 minutes and they can be divided in 20-minute subsessions. I'm going to show you what that means in a second. We're always trying to balance both acceptance of where the patient is at with encouraging responsibility. So it's not your fault that you ended up here, or that you have these issues. It is your responsibility to do something about it. And these tools can empower you to do something. So that's really the stance, being not overly rigid, not being overly passive, but somewhere in the middle. So in that 20-20-20 rule within CBT, we want to, the first 20 minutes is all about setting the stage. And regardless of which interventions you're going to use in the middle, you want to follow this format if you're using CBT. So the first 20 minutes, you're going to set the agenda. So every single session has an agenda. You don't start out by saying, how was your week? Because then you're going to spend the whole session talking about that. You're going to set up the session by saying, today we're going to talk about X, Y, and Z, and you're going to go through the agenda. You can briefly focus on what might have been going on in the past week to sort of bring in that content, but you don't want to spend a lot of time or it's going to eat up your whole 20 minutes. If you are going to be reviewing any of the stuff that we're going to talk about today, like trigger identification or high-risk planning or any of those things, then you're probably going to want to collect a little bit of information about their day-by-day use over the past week. And then you're going to review any homework that was assigned the previous time. We're going to talk in a minute about the importance of homework or practice within this type of treatment. In the middle part, the second 20 minutes, this is where you're going to introduce the discrete intervention that is planned for that session. So what skill or technique you're going to focus on. You're going to try to relate that skill to what's going on in their life so that it's meaningful. So that's why it's always good to do a good intake so you have an idea of what's going on with this patient and you can make this intervention meaningful to them. And you also want to make sure that you leave time within that 20 minutes, not just to introduce the skill, but to practice it. CBT is very experiential. We want them to use concrete examples from their life, like the traffic example. And we want them to be able to, if you're giving them an assignment or practice to do, that you work through that worksheet in session. So they have experience of using it, they know how to use it before you send them home to practice it. So make sure that within that 20 minutes you're introducing and there's time to practice or role play. Then the final 20 minutes is where you're essentially checking for understanding. So you're reviewing, did this make sense? You're asking them to do some talkbacks. So tell me what you learned today. What did we cover today? To make sure that they understood the skill. You're going to assign what they're going to do between sessions, because a big piece of CBT is practice outside of session, and you're going to view anything that might get in the way of doing that homework. Part of a relapse prevention plan of utilizing CBT is to always review high-risk situations that are coming up over the next week, and I'm going to end this lecture showing you how to do that, and then review again, what is going to be blocked out in their schedule for next time. So some of the things to keep in mind when using CBT is that it can be difficult to stay focused, especially when clients are used to a different type of interaction with you. If you're switching from more of a supportive approach to a CBT approach, this can be a pretty hard turn for patients, and so making sure that you've explained, you know, this is a different way of talking about this, and that it's going to be really important that you're mindful of staying focused on whatever the topic is at hand, and recognizing that a lot of times this stuff that's going on in their life in between sessions is just part of the difficulty that's keeping them stuck. And so shifting into a CBT approach is more focused on, I'm going to help you with this skill set so that you can be more effective with those things, but rather than just spending a lot of time supporting them around those difficulties. Making sure that you understand the homework and that you problem solve with them how they're going to do it outside of session, and really giving that rationale. And then refraining from whatever old patterns are. So especially if you're shifting into away from a more supportive stance, this can be really difficult for clinicians to remember, I had an agenda, I got to stick with my agenda. And then making sure that you are still being flexible enough to give them, to make it meaningful for them, so that you're bringing in some of what's going on in regards to the intervention that you're going to practice. General things to keep in mind, it's really, really important not to be afraid to repeat. Recognize that a lot of substance use are unhealthy habits or patterns that have been adopted and that are likely deeply ingrained. And so if we're encouraging a change in those behaviors, then we really need to be repeating with them and encouraging them to be practicing that new behavior outside. These are new approaches that maybe they haven't practiced before. Also recognizing that individuals who use substance use chronically may have some issues with remembering a lot of content. So that's the nice thing about the 20-20-20 structure, is you're really only introducing one new skill per session. So it keeps it a little easier to follow and can be more appropriate for patients who have like traumatic brain injury or other cognitive limitations that make it harder for them to really retain a lot of information. Remember that it's okay to repeat whatever concepts you've introduced, because this might be new vocabulary or new language for them. And then it's totally okay to repeat whole sessions or parts of sessions, because remember that the CBT is highly flexible, and this is about making sure that they are learning the skill. So if they haven't learned the skill, then it's okay to just repeat that, or think about how can you apply it slightly differently so that it's more meaningful for them. One of the ways that we make sure it's meaningful is that we're always clearly explaining the rationale behind every technique or skill that we want them to learn. So it's really important that you understand why this is going to be helpful before you explain it or encourage them to practice it, because they need to understand the why, or it's not going to be meaningful to them. So we're always, when we're doing good CBT, we're always stressing the importance of understanding why this is useful and why it's so necessary for them to practice it in between seeing you, because again, they're trying to change habits. Another good part of CBT is monitoring. So making sure that you have some way of tracking the practice assignments, not just saying, now I've taught you the skill, go out and practice it. You want to give them an actual tracking sheet or a homework sheet where they can keep track of how many minutes or how many days they actually practice that skill in what setting, in one context. And I'm going to give you some examples of those that you can use. It's also really important that we focus on any healthy change or positive change, because changing behavior is really difficult and changing thought patterns is really difficult. So anytime you see the opportunity to praise them, we want to take that. This really should be a positive experience for patients. Even when they're struggling with something, it could be that if they came in and they didn't do the homework or they didn't do it completely, that maybe it was too difficult of a task. And that's information for us to maybe take it back a little bit and break it into a smaller behavior or something that is going to be more achievable for them. But making sure that we're always trying to praise any effort, including just coming to your appointment. That's a big one. And then making sure that we are recognizing what's going to happen with a lot of folks. So avoidance of the practice is extremely common. So being able to talk about that, being able to talk about what might be coming up for them if they're not able to implement these skills. So it's okay to feel frustrated by this, or maybe we just picked something that was a little too difficult to achieve right now. So let's look at that and set you up to be more successful. And then making sure that you utilize the first 20 minutes to set the stage and the last 20 minutes to review what's going to happen next. That format is really important to being successful at applying CBT. This is just some language, some verbiage to be able to talk about when patients are coming in, especially with the avoidance of not doing the homework, right? I had 8 million things get in the way this week. So what can you say? Well, you can say, you know, I totally understand. How could you reprioritize? Or let's talk about, you know, why this might be important for you, or what it could help you with this week, and make it really clear and concrete. Okay, so that's basic CBT. Now I'm going to go through the 3 different techniques that fall under the relapse prevention umbrella, which is part of cognitive behavioral therapy. So most of us in the substance abuse world use this word a lot. We talk about triggers. This is a core skill that is really helpful for patients to be able to identify what their triggers are, both external and internal, and what to do with them when they show up. So to keep in mind, triggers are something, it's that thing that sits outside of the CBT box. It's something that actually triggers the thought to use, which is then associated with the craving and the behavior of use itself. So we can think about that as classical conditioning. So some folks might be familiar with this study. This was the Pavlov's dog experiment, which explained how we begin to link neutral stimulus in the environment with certain conditioned responses. So this was a study where they showed food is going to always elicit salivation in dogs. And then they paired a whistle, which doesn't elicit salivation in dogs, with the food. And over time, that pairing, they became synonymous with each other. So then the whistle becomes like the food, and it triggers the salivation. So drug use does the same thing. So it's hundreds and hundreds of different environmental stimuli, anywhere from the money used to purchase it, the street that they walk down to get to their drug dealer, the smell of the substances, the foil that they might use, and anything that could be linked that's essentially a neutral stimuli gets paired with the effect of the drug itself. So over time, it triggers that same craving that the drug does. So if you think about that for our folks, this is really difficult, right? They're just going about their life, and they might be doing a pretty good job avoiding the substance itself, but it's pretty impossible to avoid the hundreds or possibly even thousands of things that have become linked to the substance. So what we're helping people with when we're teaching them how to manage their triggers is we're helping them to understand what those hundreds of things are, and then what to do with them when they show up, so that they can begin to backtrack that cycle. They can begin to break those connections over time through habituation. So one of the techniques that we can use to begin this is something called a functional analysis. And this helps to collect information about the drug set and setting, which will identify a big chunk of their primary triggers. And then we can link it to long-term and short-term positive and negative consequences to increase some of the motivation to change or to be able to do something. So this is an example of a functional analysis. So you can see in the triggers category, we've got external and internal. So who are you with when you use? Where do you use? When do you usually use? What are you usually thinking about? This is the internal stuff. What are you feeling physically? What are you feeling emotionally? What is it that you use? How much? So this is information about the drug. And then questions about the positive consequences and the long-term negative consequences. And this helps really to increase sort of like, now what do I do now that I've identified what these things are? One little note that's also helpful, and once you've identified some of these triggers, is to remember that people tend to change when things are reinforced. So a lot of these triggers have been reinforced in the past because they've been connected to the use. And that's a positive association, even though there's a ton of negative consequences connected to it. The use itself is a positive association. So we want to think about how can we begin to match healthy rewards to non-use behavior. Punishment can work too, and that's where a lot of our folks tend to go right away, is sort of focusing on self-punishment. But in the long term, that's not that helpful. So we can explain that to them and say, what can we think about that you could use as rewards to actually make some of these changes that you're trying to implement more sustainable and more effective. So some of the things that we can set up contingencies both in our relationship with them, so rewarding them for coming to services, rewarding them for non-use, and thinking about ways that we can support that. And we can also give them some techniques to do this in their own life. So thinking about what is a triggering situation and how is it connected? What's the contingency that it's connected to in terms of their use, right? And then what could be an alternative? So what could they do that would be also a positive reinforcer, but connected to non-use, right? And making this really clear for them so that it's a choice that they're making, rather than putting themselves in the situation and just waiting to see what happens, because the likelihood that they'll be successful is pretty low. So once we've helped them identify what their triggers are, then we have to teach them a set of skills to manage those when they show up. And this is called urge management. Because remember, they always have the trigger happens, they have the thought that's connected to the trigger. So those were those consequences that we identified. And then we have the urge or the craving that shows up. So what do we do with that stuff? So one of the things that you can use is called an urge management table, is helping them to identify the difference in trigger and intensity of craving or urge to use, and then what they can do to manage that. Teaching them that urges are temporary, that if they do nothing but just sit there and don't move, eventually it will get better and it will go away. That's typically not the best plan of action, but that's one coping behavior that they could use. I sit still and I don't move until it goes away. But we can give them a whole slew of other things that they can do, from distraction to seeking out social support, to talking about it, to going to a meeting, to doing something creative, to imagining the substance itself as something toxic that they don't want to put into their body. All of these things are coping behaviors that can be used to manage the urge. What we're wanting to teach them here is that not all triggering situations are going to have the same level of intensity. So going to a park where I used to score might be like a 70 versus actually being in my drug dealer's house is going to be closer to like a 99. Those are different levels of intensity, and the higher the intensity of the urge to use or the craving, the more likely I am to succumb to that and actually have a slip. So we always want to match intensity with intensity. So when we're teaching them is first to identify the level of intensity that they're experiencing, and then we want to help them to identify a coping behavior to manage that intensity that is equal, right? So maybe sitting and coloring isn't probably going to be that effective when my urge to use is a 99. That I might need to actually call a friend or get myself out of that situation, or do something that has a higher level of intensity to match it. So we want to be teaching them that, and this table is very helpful. This is another one that you can use to help people track their amount of urges and how they handle it. Also to begin to identify the triggering situations and the thoughts and the feelings that are connected to it. And then urge surfing, I think I already mentioned a lot of this, is teaching them techniques to be able to manage those temporary urges to use when they show up. So recognizing that they're like waves, that they rise, but then they fall. You don't have to respond to them. Typically they peak within 20 to 30 minutes. So again, if somebody just sits still for 30 minutes, likely the urge will expire on its own. It's okay for them to come back, The more they practice without giving into the urge, the better they'll be able to manage it, and the less intense it will feel over time. So the key is to not act on that urge, and eventually it will extinguish itself. So that's why it's really important with urge management, that we're teaching them skills to be able to label them correctly and to have something to do with it. And then lastly, and this kind of goes with identifying some of those situations, you want to wrap up every single CBT interaction that you have with somebody with identifying high-risk situations, or this is called high-risk situation planning. And this is something that you do on a week-by-week basis, or if you're going to have a month between when you see somebody, you want to go over 4 weeks of potential high-risk situations that could be coming up. This is their emergency plan, and if they're not planning for those urges to be really high, or the likelihood that they're going to be in a situation where they will be triggered to use, then they're not going to know how to manage it and to do it successfully. So the first thing we want to explain is the difference between high-risk situations. Those are situations that are going to have a really intense trigger with a high urge to use, versus low-risk situations. That's being around people, places, or situations that are not necessarily associated with a high-level trigger or a high urge to use. So we want to teach them to decrease how much time they spend in high-risk situations and increase the amount of time they spend in low-risk situations. So we want them to start to shift that balance. This is an example worksheet that you could use with anybody on a week-by-week basis. Just wrap up your session with going through one of these, and you identify, okay, what's coming up over this next week that's a high-risk situation, and let's write down the next 4 situations that you anticipate, like going to a birthday party where my cousin who used to sell to me is going to be there. Okay, that's situation 1. How are you going to handle this? And you want to give them at least 3 plans. And this is something that can be very collaborative, but very concrete. Who exactly they're going to call? Can they bring somebody with them? Can one of the plans be, I don't go to the birthday party, right? That can be in there too. So helping them to identify so they have multiple options that they can choose in that moment to be successful. And this is something that you encourage them to keep on them, to keep in their wallet, to keep in their car, to make sure they have this so that it's available to them in the moment when they're being triggered and their frontal cortex isn't functioning that effectively, and they might need some of this assistance to follow through. It's really important that you do this every single week, or sometimes even daily, depending on how frequently you see them, because again, they're learning a new set of skills, and they probably not had a lot of experience planning out their day, implementing that structure, and following through on it. So it can be very useful for them to have a schedule that includes their high-risk situation plan, and especially some of the practice work that you're encouraging them to do. Okay, any questions about